Welcome everybody. I am truly happy of being today together, remembering also the wonderful day passed by yesterday together with the friends from Central America, today broadcasting from West Indies, but as always starting with the image of the spectacular Italian pavilion at the Universal Expo made by 3 upside-down boats that, as we always say, is a metaphor of the journey we are all having around the world, and that we look forward for bringing us in the spectacular venue of Dubai during the Universal Expo. Indeed, when we will connect experts informing patients for venous and lymphatic fake news-free communication. As said yesterday, we deeply enjoyed spectacular colleagues from all around the world, but in particular from Central America, speaking in Spanish. Today, we move to English and we move to West Indies in this global collaboration that is indeed allowing everybody to make questions in whatever language, remembering the question and answer box, not in the chat, so that we can see them and reply in live if we have time, if not in written forms. Today, we will keep on providing international CME credits, so remember to rely on our organizing secretary. And today, once again, we move forward with this new project called 4x4, because it is indeed bringing together general and internal medicine specialists together with venous and lymphatic experts, starting indeed from Central America and West Indies. This is a very important topic to us because, as you know, we have a focus on evidence-based data, and the evidence is showing us that whatever specialty we are practicing, we have more than 50% of chances of dealing with venous and lymphatic disease patients, whatever the issue they have is. And for this reason, we are definitely happy and honored to co-work with specialists from internal medicine and also general medicine and all the venous and lymphatic experts from all around the world. We worked with 3 great colleagues to prepare the slides you will enjoy during these courses, together with the great experts from the region that I'd like to deeply thank, together with Servier, for having allowed this educational experimental project. As always, nothing would have been possible without the friends and colleagues I'm used to say I consider family. So now the word goes to Oscar Bottini.
Welcome, everybody. Hope you enjoy this new educational proposal called 4x4. Sure.
Thank you. You basically behave like Willy usually, is like very short. So here we will have also Willy introduction.
Dear friends and colleagues, good morning, good afternoon, good evening. Unfortunately, I won't be joining you for today's excellent 4x4 webinar. I hope you enjoy the program, and I hope to see you soon.
And with this, we deeply thank Professor Chi for being always a pillar of all our activities from the day one. And the difficulty of not having him with us today because of connection issues is, as always, give the opportunity to meet new great figures. For the opening in this case, Professor Taha, who is a dear friend, a great colleague, with whom we have had the honor of co-working in the LATAF project. So Wasila, the mic is yours.
Thank you. Thank you so much, Sergio. And since I replayed the great and fantastic Willy, so good morning, good afternoon, and good evening, everyone. But truly, I'm honored to take part of such a great opening of the great 4x4 educational initiative. It's, I say that it's a wonderful and brilliant idea to conduct educational streamlined initiative dedicated, and to my knowledge, for the first time, dedicated to non-vascular doctors, internists, GPs, and in outstanding way to bridge between the isolated islands and fill the gaps with updated top-notch science. Congratulations, VWIN family, and I'm deeply thankful for the huge opportunity. Thank you so much.
Thank you so much to you, Wasil. As per tradition, we have always an honorary chair that in this case is from the general medicine ward and is also a surgeon and is a godfather of many of our initiatives around the world. So it's my true honor and pleasure to introduce the opening remark of Dr. Noce, Italian Board of Physicians President for the Veneto region.
Dear all, representing the Italian physician is a true honor and a pleasure for me today. In particular, I appreciate the attention and the venous and lymphatic specialists ward toward the general and internal medicine teamwork in time management and so frequent pathology like chronic venous disease, venous thrombosis, and lymphedema. Family medicine and internal medicine are the front line in the proper disease management and the public health awareness development. I congratulate then all the colleagues involved in this educational brilliant initiative that will represent an opportunity for many patients to receive always better health care. Hoping to meet you soon in Italy, congratulations again.
We deeply thank once again Dr. Noce for having been a splendid ambassador of the venous and lymphatic ward in the general medicine ward. And since indeed general and internal medicine synergy is the thing we are looking for in this project, we have the honor of having a representation of the internal and general medicine also from Barbados, thanks to Dr. Williams. And here is her welcoming remark.
Good morning. My name is Dr. Linda Williams, and I'm the president of the Barbados Association of Medical Practitioners, BAP. It's my pleasure to welcome you today to the 4x4 Medical Educational Seminar on Evidence-Based Venous Lymphatic Principles. This important seminar has been organized by the International Venous Lymphatic Network, VWIN Foundation, in collaboration with Servier Central America and the Caribbean. The agenda for the seminar includes the pathophysiology, management, and classification of venous disease, as well as international perspectives. These lectures will be given by experts in the field, and we should all come away enriched and enhanced by the knowledge which is being transferred. It is important that we do not take venous disease for granted and trivialize this important syndrome. Our practice should change as a result of having been here, and it is my hope that you enjoy the rest of the seminar. Thank you.
We deeply thank Dr. Williams, and now we get started with the scientific trip that will lead us to the first of the 4 modules of the day. I have the honor and pleasure of getting started, and my topic is chronic venous disease pathophysiology. These are my conflicts of interest. Well, I'd say that in order not to lose the interest of our colleagues from the internal and general medicine ward, rather than talking just about pathophysiology, I would start with the definition of a varicose vein. Because it's clearly not just a tortuous dilated vein as the one we see clearly in the operating room. It is more the presence of a venous hypertension answer from our body. Venous hypertension is the key message because indeed it's all about physics. It's about those laws of physics that rule the venous drainage and that, as you can see, force us to always assess our patients while the patient is standing up rather than lying down. A fundamental law of physics is the one of Poiseuille, that is stating that in order to create a flow between 2 points or a reflux, all we need is a pressure gradient. Now, to create this pressure gradient, we have, of course, a pump that is pushing from the back, and that is clearly the heart. But we have also a pump that is usually not considered, that is in the front and is aspirating this blood to create the gradient. But in between, we have the real heart, what we as vein lymphatic experts define the peripheral heart. That, as you can see, is propelling the blood from the lower district toward the heart. And as you can see, interestingly, you have the main heart here in the cuff where you have 65% of the ejection fraction. That is, interestingly, quite close to the ejection fraction of the central heart. For this reason, we usually suggest that to our patients to go walking to activate the pump rather than by bike when they are activating the thigh. It's also interesting to notice by the literature that the more disease we have, the more decrease we have in the ejection fraction of our cuffs. But don't forget about the foot, because over there we have a very important network of veins that is pretty peculiar. As you can see from the girl, usually we have a venous drainage from the surface toward the deepest compartment of the leg. Not in the foot, where we have in reality a drainage that is going from the center to the surface and then into the saphenous compartments. And this is to say that it is very important not to overtreat the veins of the foot that are paraphysiological. And it is very important to make sure that the posture of our patients is perfect, because if they are not putting down the weight in the proper way, as you can see, they have an increased risk of developing venous insufficiency. It's like if the walls of your house is not really straight and it's a little bit leaning down, and then of course the pipes inside the wall are not behaving well. Michael Jackson, with his moonwalk, is reminding us of the importance of the ankle range of motion that is activating this pump. So always remember to properly evaluate also the mobility of your patients. Now, all these pumps, when everything is going on well, are pushing the blood, of course, toward the heart, and then the wounds are impeding the reflex toward the distal parts. If there is an incompetence of these wounds, we have problems. We have reflux, we have inflammation. And here is the clear picture of the situation we face. As you can see from the picture we published with our research group, these data showing the importance of the bones. For example, the absence or incompetence of the bones above the saphenofemoral junction are increasing up to 5 times the risk of having refluxes and recurrences after the treatment, for which you want to receive always a proper report from your sonographers. And it's great that we have Wasil Atta, one of truly the greatest sonographers in the world, that can dive into the topic a little bit more. Because indeed, this is a topic that is not just about spider veins and aesthetic concerns. We will have a dedicated talk about the CERP classification by Professor Santiago, but as you can see, there is a series of different clinical scenarios that really starts from some spider veins, but goes all the way up to conditions that is considered more impacting in the quality of life that chemotherapy for the patients. And consider that once you arrive up here, you cannot go down anymore. Once you are like C5 or C6, there is no chance to go back to C4. So we really have to act on time, also because it's not like so rare, actually, it's very frequent. Think that up to 2%, and even more if you look at the elderly population of indeed the people we meet along the street are affected by this serious condition. That is clearly related to venous hypertension. And when we are talking about venous hypertension and pathophysiology, we understand that this hypertension is inside the vessel that is expressed by transmural pressure as venous hypertension, which is the difference between the internal and the external venous pressure. Now, the internal venous pressure has different components, and we can dive during the discussion into the details if you want. And the external pressure, of course, has its own components. You understand already now how, for example, a graduated compression is acting on the external venous pressure, while the venous active drugs are more acting on the internal venous pressure, but also on the external venous pressure if you're talking about edema in general. But we are not just standing up, we are moving. And since we are moving, we have to apply other pathophysiology and laws of physics principles like the one of Bernoulli. That is basically stating that whenever there is an acceleration inside a vessel, there is a lateral pressure drop. Now, if I can be quite nationalistic and go to the Italian leg that you see over here, where we have a femoral vein highway and a great saphenous vein freeway and different perforating roads and tributaries, we understand that these pressure gradients are translated into different velocity gradient. This is a series of publications we have been doing with our research group, showing how the deepest compartment has the vessels deeply inside the muscles, for which every muscle contraction is giving a direct push to the blood. The pressure will be a little bit less in the saphenous system that is not directly in contact with the muscle, a little bit less in the tributary systems that are navigating in the subcutaneous tissue. We demonstrated by this paper that are available on Phlebology Journal that there is indeed a velocity gradient that is leading to the Venturi's effect, for which we have an aspiration from the surface toward the deepest compartment. And that's how the venous drainage works. Also, when there is a pathology, for example, when there is a reflux, so the blood is going in the reverse direction because this velocity gradient is aspirating toward the surface rather than the deepest compartment. And this is happening because some bones are failing, for example, at the saphenofemoral junction or at the confluence between the incompetent tributary and the saphenous trunk. Now, what we do is basically an hydraulic work. We are fixing the pipes, meaning that we are just fixing the area that are incompetent in order to restore a physiological drainage back to the deep system and to the heart. This is another publication of our group that is showing how by doing so, we are not just changing physics, we are changing also biochemistry. We are changing the inflammatory biomarkers that can be restored after a proper treatment. And in this case, not even removing the saphenous trunk, but simply closing the leaking points. And this will be a topic for another discussion. Stopping the inflammatory process is of fundamental importance. This is a nice paper that is showing how varicose veins are not just varicose veins as an aesthetic issue. They are an inflammatory process that is significantly increasing up to 5 times, but even more according to other publications, the risk of having a thrombosis. And it is interesting how this inflammation is getting systemic, interesting also the peripheral arterial disease that is increased indeed in these patients. It's a vicious circle, the one of venous hypertension, that is, of course, starting from the dilation and the failure of the bones, that is creating an inflammation that is creating further damage to these structures. But not just that, it is also creating a damage at the level of the lymphatics, so increasing the edema, that is, of course, increasing the inflammation and then starting again the vicious circle. You understand how a proper procedure on the venous system and a proper, for example, graduated compression stockings or compression in general can act on the venous hypertension and dilation part of this scenario. In the same way, you see how venous active drugs can act, of course, on the restoration of the anatomical structures in terms of inflammatory control. It's not just about size. I really like this quote of the lion that is saying, if size really matter, well, the elephant should be the king of the jungle. This is to say that if you receive in your office patients with dilated varicose veins, it's just not enough to say, just go for treatment. Of course, size is important and there are cutoff values considered pathological. But as you can see, the sensitivity and the specificity of these values is pretty low. And indeed, we know that there is a correlation with the BMI, but not that much with the other severity scores. We know indeed that if we overload these veins with a lot of volume, like with the athletes, we can have a dilation that is not associated with the pathology. But at the same time, we have to be careful because, of course, also athletes can be affected by pathology. So we really have to look for hemodynamics, and not only because it's not just what we see macroscopically, for example, with an ultrasound. This is a very interesting paper that is showing how at the very beginning of the disease, even before seeing spider veins, we have a functional capillary density that is decreased. This is a sign that there is a domino effect that is starting very early at the microcirculatory level, affecting then the macrocirculatory aspects. This has been testified also by papers like this one, showing how, for example, MPFF has been able to control symptoms without changing hemodynamics parameters. This is suggesting us that there is something more than what we see. We have to move at the microcirculatory level, and we have to be cautious when we have patients having no symptoms, because in reality, there could be something going on because of what I said at the very beginning. Varicose veins are just the natural response to the venous hypertension. So until they are dilating, you don't usually get that much symptoms. It's when they are not dilating anymore that you are having issues. And indeed, if you think about ulcer patients, usually they don't have so visible varicose veins. At the same time, I'm concluding, we should never forget about the hidden epidemic that is strictly related to this topic. So lymphedema, hidden epidemic is how it has been defined by the World Health Organization. We could say that veins are like rivers and lymphatics are like creeks going into the river. So we know that they are strictly interconnected. And we know that also thanks to papers like this one, showing that when we have varicose veins, we have also a delay in the lymphatic drainage in the same area. Now, I could not be more excited than now in presenting to you what, up to my knowledge, is the very first picture showing in a human the presence of the glycocalyx. This is a research we are going to present soon. And here is the very first picture showing this endothelium lining that is characterizing another aspect of similarity between the venous and lymphatic system. It's very important then that we all work together, putting the patients at the center, having the general and internal medicine involved in the very first line in order to improve our evidence-based practice for our venous and lymphatic patients. This is a paper showing how more than 40% of medical websites are including fake news that are usually shared more than 450,000 times. This is our responsibility, I think, as societies and as experts to gather together and take this chance to deeply thank the more than 70 societies who are already taking part in this group global effort in fighting, indeed, medical fake news. If you encountered them in the venous and lymphatic field in particular, please report them in this website in whatever language. They will be part of a consensus document that will be presented in the Universal Expo week dedicated to health and published, of course, in an indexed journal. And of course, presented, as I was saying, next February during a special time of the Universal Expo dedicated to health, where I hope we will be together in person. With this, I deeply thank all the ones involved in this project, and in particular, Dr. Arnan, who will follow my talk with this talk, dedicated always to the evidence-based practice of venous and lymphatic medicine.
Hi, good afternoon. My name is Dave Harnanan, and I'm a vascular consultant attached to the Eric Williams Medical Sciences Complex in Trinidad and Tobago. Today, I'm going to talk about venous disease. And I'm going to make some bold statements to start. Venous disease is one of the most common disorders affecting the population of both the developing and developed countries. It's a major socioeconomic problem that's associated with a high cost burden. And many of our patients present with early disease. Up to 85% of our patients. 40 to 60% of our patients will present with varicose veins. And about 7 to 15% of our patients will present with some degree of advanced disease with ankle edema. About 1% of the population in the Western countries will have either an active or a healed venous ulcer. This data is, these statements that I'm making is based on data generated from Comoretta et al. In 2009. And let's look at this in a little more detail. Looking at the Bonvein trial and some data generated from a screening study from the US and the Vein Consult, we can see that about 50% of our patients will have early venous disease with telangiectasia and varicosities. A percentage of our population would also have active venous ulcers or healed ulcers. And it's point to note that in the Vein Consult trial, we demonstrated that ulcers accounted for than in the developed countries. And this is mainly because of a lot of patients in the third world environment would not have early access to healthcare. And this is a similar pattern that is demonstrated in the Caribbean islands. With respect to the Vein Act program, looking at patients who presented to GPs, we have been able to recognize that up to 40% of our patients will present to general practitioners. And when they present, men are more likely to present with severe disease, and women are more likely to present with early disease with telangiectasia. Men will generally present with ulcers and varicosities. They present with varying signs and symptoms, heaviness, leg pain, swelling, cramping. Many of them would present along this pattern. And when they present to our GPs, we know that over 90% of them will be advised appropriately to lose weight, exercise, and leg elevation. A similar pattern happens throughout the Caribbean islands, where a great percentage of our patients are put on venoactive drugs. But only 2/3 of our patients would be recommended for compression therapy. And of that 2/3 of patients, only about 40% of them will be prescribed the correct compression therapy. Having said that, this accounts for a major cost to our patients. We know that 15% of patients will have lost days of work associated with chronic venous disease. We've been able to demonstrate that chronic venous disease is progressive. It gets worse with time and has a propensity to recur. And with this is going to be an increased cost. But can we predict and avoid the evolution of venous disease? Can we predict those who will move on from varicosities to ankle edema, to lipodermatosclerosis, and venous ulcers? These are the typical type of patients that we will see in the Caribbean environment. A lot of our patients will present with large venous ulcers, lipodermatosclerosis, active ulcers that are infected and severely painful, and venous eczema. These are the usual pattern of disease that will present in our environment. To manage these patients are quite challenging. For us to understand whether these diseases progressed from early to more advanced stages, we got to understand the pathophysiology of diseases. And it is well accepted that valvular reflux is the predominant determinant of both chronic venous insufficiency and varicosities. There's an ongoing discussion whether it is that the valve dysfunction initiates the venous disease or whether valve dysfunction is secondary to venous remodeling. Systemic venous hypertension accounts for the main problem here. And it's important for us to understand this, similar to systemic arterial hypertension, where venous hypertension is the main underlying factor that eventually contributes to inflammation, culminating in abnormal permeability of the capillaries, remodeling of the vein walls and valves, and necrosis leading to ulceration. This is similarly seen in patients. When we think about renal patients, we've done an AV fistula for. The veins undergo remodeling and thickening of both the valves and the walls. And this is a similar thing that happens when we have venous hypertension. This venous hypertension will eventually transmit to the skin capillaries and contribute to inflammation and skin necrosis, forming ulcers, red cell extravasation causing venous eczema, and fibrosis and lipodermatosclerosis. Understanding the distribution and the pattern, anatomical pattern that happens, it's important. Previous thinking was that it was a descending theory where the incompetence happened at the proximal valves. However, now we're thinking about segmental reflux happening, and then this may progress on to multi-segmental reflux and ultimately contributing to our venous problem. The thinking here is that it begins at the lower levels of the leg and progresses in an antegrade or retrograde fashion. Laprolas et al., when we look at the rate of progression, spoke about, after he followed the patients for 18 months, recognized that about 7% of our patients would progress. However, if we were to follow them for longer periods, we'll see that 90% of them would progress. And we know that patients with secondary venous disease are more likely to progress, as seen here. The Edinburgh vein study was the data we have available to us that clearly helped us to understand what is going on and with respect to progression. This was data where we followed up the patients for 13 years, and we've been able to follow 880 patients at 13 years. And what we see is that about 50% of our patients are going to progress. We know that family history has a significant part to play, and patients with a history of deep venous thrombosis also progress more rapidly. Additionally, patients with varicosities, obesity plays an important role. However, having said that, looking at this trial, patients who had reflux at baseline, only 11% of them progressed to advanced disease. And for patients who had no reflux, similarly, only about 10% progressed. So it does add some doubt as to what we're going to do. But overall, we know that more than 50% of our patients will progress. We know that there are some known risk factors for progression. It's expensive and burdensome problem that we have to sort out, but still there remains difficult for us to predict which patient will progress and how fast will they progress. Bearing that in mind, progression is variable, but we have to understand that family history, secondary causes, and obesity play important roles in progression of disease. Thank you for listening.
And with this, we deeply congratulate Dr. Arnano, who is here with us. And we move now to the part dedicated to both the general internal medicine representatives and the representatives from the venous and lymphatics ward. It will be Professor Bottini introducing these two special guests.
Let me introduce Dr. Lau Ekien, general practitioner from Curaçao. Dr. Ekien.
Yes, of course, there are, like always, connection issues, particularly in these days of storms from West Indies. So we have the question here.
Hi, thank you for the presentation. My question is, in patients with ulcerations due to venous insufficiency, is it better to combine Daflon with venous compression stockings, or is Daflon alone sufficient? And in what percentage does this help with the calf ejection fraction? And will this also be the same for patients without venous ulcerations?
So this question was for me, and I think this is a brilliant question because it offers us the possibility to brainstorm about a lot of things, and I would open the discussion eventually with all the other experts. Now, the colleague was asking us about the combination of MPFF and compression for venous ulcers. Now, first of all, I would say that there is no venous ulcers. There is a high potential risk of having multifactorial ulcers, so we should always not discriminate just venous, because we have basically 20% of cases being multifactorial. Having said that, the mandatory message, I think, is compression has demonstrated that if you don't apply it properly, you are going to have 9 times the risk of recurrences also. So compression must be there. It is very interesting, she mentioned the MPFF component, because just a few days ago, Professor Nicolaides' group published a meta-analysis showing that venous active drugs can help in venous ulcers healing. They demonstrated that the best 3 are sudocetaxide, pentoxifilin, and MPFF in order. So first sudocetaxide, then non-inferiority for pentoxifilin, and then MPFF. But this is for venous healing rate. We should embrace the whole concept, I think, of ulceration, which is the impact on the quality of life, on the symptoms, and also the cost. So for this, I think the topic is really broad, because again, we talk about venous ulcer healing rate, but we should talk also on the impact of symptoms and so on, where it is fundamental to rely always on evidence-based products. And in this, of course, we have the evidence on MPFF, as she was saying to us. The other thing that she said to us is the eventual role in the ejection fraction. Now, this is interesting because 20 years ago already, Ting demonstrated that there was no significant improvement in the ejection fraction by using venous active drugs like MPFF. We have also contradictory data on that because it really depends on how we measure that. But I don't think that it is really a matter of just ejection fraction, because we know we can improve that with proper compression, for example, in particular with inelastic and progressive compression. But it is more the microcirculatory aspect I was pointing out, for which venous active validated drugs might help. And not just, of course, in ulcer patients, but in whatever kind of venous patients, and maybe not even in just venous patients, but in patients at risk of developing swelling, like, for example, prolonged standing, or in situations of particular effort, like even sport athletes who are exerting particularly with a lower limb. So, Oscar, now I will pass the mic again.
Sergio.
Yes.
Thank you, Sergio. Excellent answer. Now, it's my pleasure to introduce a through leader, Professor Sasa Lazarashvili from Georgia. Sasa, whenever you are ready.
Thank you very much, Sergio. Thank you very much, Oscar, and all friends. Sergio, it really was Grossmeister's presentation for so short time, and all based aspects of the venous pathophysiology was presented. My question is that how we can use the ankle joint movement parameters in routine clinical practice. For example, for the evaluation of ankle myofascial pumps function.
Thank you so much, Professor Salvatore Lazarashvili. Now, this is a very brilliant question because it is not so investigated up to my knowledge yet, meaning that we have been co-working with the physiatrist on different publications we have done, particularly in the aquatic environment. And we demonstrated that if you apply a standardized protocol of exercises into the aquatic environment, you are able to increase this ankle range of motion. And we demonstrated that there is a correlation with the lower limb variation. So there is really a pump effect. Now, up to my knowledge, there is no real agreement on the physiological parameters and on the pathological parameters. And statistically, you see already significance in values, for example, of 4 or 5 degrees that are not even considered statistically significant for the physiatrist in the everyday practice, which means that we should speak more, I think, with the experts of movements like physiatrists to co-work working on the peripheral heart, that is, of course, the calf and related ankle movement. But to answer practically to your question, we just have to do what we were doing in primary school, just get our goniometer and use it in a standardized way in our patients and see if after adapted physical activity that we should apply in our everyday practice, this ankle range of movement will improve. And this should be also correlated with the edema management of the same patients. I hope this answers your question. I think we have also Professor Shaidakov with us, and I don't know if Eugene would like to make a question. I see that maybe he has some connection issues. Eugene, are you with us? No. Yes. Would you like to make a comment on this? I know you are passionate about venous hemodynamics as well. So
just a minute, Sergio.
We can hear you.
Yeah, here. Sergio, thank you very much. It's a fantastic presentation, and we have our own experience in this area. You know that our modern phlebologists and our young phlebologists in Russia have a new view for this problem. But I agree with you. It's very, very important, and I think that we need to compare our results, and we need to translate your presentation to Russian. It will be very, very important to our daily practice. So we will talk about it and we'll do it in the nearest future, of course.
Thank you so much, and congratulations for the publication of the guidelines.
We told about it with you. Thank you very much again.
And I'd like to take this chance to congratulate you, because you put evidence on C1 patients with new guidelines dedicated to this. So we look forward for the other translation from Russian to English for knowing more about that. Now we move forward, and we move to Dr. Arnan as a speaker and the related questions. It is my pleasure to introduce the General Internal Medicine representative, Dr. Marajai from Trinidad. And here is the question for Dr. Arnan.
Good afternoon, everyone. My name is Vindra Maharaj. Thank you for the opportunity to participate in this webinar presentation. Also, thank you to Dr. Harnanan for your excellent presentation of chronic venous disease and its proper management. In terms of proper treatment, you mentioned that 2/3 of our patients are recommended for compression therapy. And of that 2/3 patients, only 40% will be prescribed the correct compression therapy. How can we go about educating our GPs in prescribing that correct prescription for compression to optimize disease treatment and hence help to decrease the progression of disease? Thank you.
Dr. Harnan?
Okay, so Dr. Maharaj, thank you for that question. And I know later on in the conference, we will be spoken to about the benefits of compression therapy. The answer to the question is multifaceted, but the main part is through these educational webinars and seminars and venous workshop. This would be the way that one of the major ways in which we will be able to educate our GPs and our other healthcare professionals. Similar to this type of meeting, and I have to pay special kudos to the organizers of this meeting for having the foresight to understand that we need to educate our healthcare professionals at all different levels. However, having said that, I do think that this is a subset of a much larger problem, especially that we face in the West Indies and the Caribbean. Now, the data that I presented was taken from the VANACT program, of which one of the investigators is Dr. Dale Maraj, who is presently on the in the audience. And I have to give special mention to Dr. Maraj for being a pioneer in management of venous disease in Trinidad and Tobago. And he actually contributed to this paper in which they looked at close to 8,000 patients. The contribution from the West Indies was about 195 patients. Now, all of the data would have been pooled together and then presented. However, if we were to, I'm sure if we were to do a subset analysis of this group of patients, we would probably recognize that patient adherence to therapy even the modes of presentation are going to be far later, and our treatment protocols may be varied. Essentially looking for data on venous disease in the Caribbean, there's a significant paucity of data in the Caribbean. Very little is available for us. And I think in order for us to be able to understand this properly and through the collaborative effect of all of us in the Caribbean and from our senior colleagues, similar to you guys, our experts on the panel, I'm hoping that we can be able to do some degree of research where we're able to quantify the prevalence and severity of the disease. And that would allow us now to be able to recognize that this is a major problem and may even consider it as a non-communicable disease, which will then allow us to focus our attention on educating the patients on compliance with therapy, also educating our healthcare professionals as to what is the correct modality of treatment and what is the treatment protocols we should follow, and would allow us to encourage some resources to be geared towards management of venous disease. So yeah, I think these webinars are very useful. And I do think that if we were to able to collect data and identify the problems, then we may be able to more effectively manage these as these venous problems. I hope that answers your question.
I guess so. Thank you, Dave. And now we move to the specialist from the venous and lymphatic, and not only, also arterial expert, a huge expert from the field. I'd like to deeply thank Professor Armando Mansilla, a real huge giant in our field and a true gentleman who also made possible the presentation of Dr. Arnand co-working with us in the preparatory material and also giving some of his slides. Here is his question.
Thank you for Professor Sergio Gianesini for this kind invitation to participate in this global initiative to discuss and approach this important topic for all of us clinicians. I was very pleased to analyze the previous presentation and remember many of the slides that I already presented in the past. And I wonder to know what can be done at the GP level in order to faster identify the chronic venous disease at the early stages and avoid the progression, and also what can be done at GP level to better treat the venous ulcer that we know has a huge impact on the quality of life of the patients. Thank you.
We thank once again Professor Mansilla. Dave?
Yeah. So again, I must say special thanks to Dr. Mansilla for allowing me to present a lot of this. What I presented was from his slides. So at a GP level, it requires us to, again, as I said, quantify the problems so that we may be able to accurately understand what we are managing. I think we must establish some degree of protocols that would allow us to identify the problems, put protocols in place to allow them to manage the patients effectively, and more importantly, to refer the patients early enough. Management, wound care management, especially in the Caribbean environment, is at times not well organized. So with respect to venous ulcers, recognizing the proper management of wound care, compression therapy and early referral, I think would be very useful in managing venous ulcers. And again, I hope that answers the question.
Absolutely. And with this, Dr. Arnand, we finish our first round, let's say metaphorically, with the 2 educational car on the 4x4. And we approach the third one, but not before congratulating you, Dave, for the brilliant work. It has been truly a pleasure to co-work with you, Professor Rial, Professor Bottini, and Professor Mansilla on this. Now we move on the way to Brazil with another big expert that I see is here with us. So I guess you will go live, Fabricio, right?
Yes.
That is great. So let me introduce Professor Santiago properly. He is a giant from Brazil. He's a huge expert with particular focus on compression. And we will enjoy today is talk about the new CF classification and proper symptoms and signs report. He has been also part of the committee dedicated to the CF classification update. Fabricio?
Can you see my screen?
Yes.
So following the tradition from my dear friend Willie, good morning, good afternoon, good evening, everybody. My name is Fabricio Santiago. I'm a vascular surgeon from Brazil, and I'm here to talk to you about the new CF classification and proper symptoms and signs report. I have no disclosures for this presentation. I'd like to thank the organizing committee, the WIN Foundation, for this kind presentation. And the first the first CEP classification was reported and published on 1994. We all know that. The first review was published, and the first review was published on 2004, and only last year we had the latest version published, and I was gladly part of it. And this presentation is going to be more descriptive for those who are not familiarized with the classification and for those who are not familiarized with the new update. So regarding the clinical aspect of the CEP classification, we all know that we can have patients with going from C0 to C6. And now from this latest review, we have a patient C2 with categorized as C2R, is a patient with a recurrent varicosities. We have also in C4 a C4C, that means a patient has a corona phlebitis. And in C6 now, we have a C6R, that means that a patient has a recurrent active venous ulcer. From the etiological aspect of the new classification, we keep the primary, secondary, and no cause identify and congenital categorizing patients, but we also now have the division of secondary can be intravenous and or it can be extravenous. It's important to notice that the document states that the same patient can have the different types of etiological aspects of the disease. Some examples of intravenous causes: a patient with post-thrombotic syndrome caused by a DVT, patient with an arterial venous fistula, or more rarely some cases of endovenous tumors. From extravenous causes, we have central venous hypertension caused by obesity by cardiac heart failure, some venous compressions that can be anatomical, just like the Matern syndrome, or a tumoral, some fibrosis in the abdominal cavity previous to a surgery, or muscle pump dysfunction. And from the anatomical aspect, we previously have the description from numbers but now we have them going from the acronyms of the anatomical aspect that is affected, including the anterior accessory saphenous vein in the description. From the pathophysiological aspect, we have no difference on the latest review, but it is important to notice that the advanced nerve vibrations for the anatomical aspects need to be reported under each P or pathophysiological class to identify anatomical locations corresponding to the P class. This is very important. It's important to notice that the CEP classification is descriptive. It should not be used for the outcome comparisons. So for that purpose, we have some other very nice tools, just like the VSS, but I'd like to call your attention to be careful by using VSS in low CEP patients, because you won't have differences when comparing it. For that purpose, you should use specific quality of life questionnaires. According to most of the guidelines, we have a very high recommendation grading for use the CEP classification with a very good scientific background for that. We know that. And this is the basic description of the CEP, and this is the advanced one. We should not be scared about it, because on our day-by-day practice, we use only the C classification. And here we have some the latest publications from some papers published that they are reporting only the C classification, although the committee highly recommends to use the complete C classification. So regarding the symptoms, it's important to notice that it's something that it is described by the patient and elicited by the physician. We have several types description of symptoms based on CEP classification, on VCSS, the Bond study, or quality of life questionnaires. And this is what the CEP classification brings us from the 2004 publication. Is a patient with an aching, a pain on their legs, a sensation of tightness, skin irritation, heaviness with muscle cramps, or other complaints attributable to venous dysfunction, although I think this is a very vague description. I highly recommend you to use the list of venous symptoms reported by the SIN vein consensus from the International Union of Phlebology, and we can have a patient with a pain or aching, throbbing, sensation of tightness, heaviness, especially at the end of the day, sensation of fatigue, feeling of swelling, cramps, itching, restless legs, sensation of tingling, and heat or burning sensation. Regarding the signs, we can have patients with C0 with no signs at all, but we should remember that these patients can also be symptomatic. Regarding the classification, the clinical classification itself, I'm going to show you some examples for those who are not familiarized with the signs of the C classification, we have an example of a C1 patient. They can have telangiectasis and or reticular veins. A patient C2 is a patient with varicosities, with varicose veins, and a patient now a C2R is a patient with a recurrent varicose veins. A C3 patient is a patient with edema. It is important to notice that a C2 patient can become a C3 patient at the end of the day, and these patients can have, along with the edema, varicosities, telangiectasis, and or reticular veins as well. A C4 is a patient with the changes in skin and subcutaneous tissue secondary to chronic venous disease. A C4A is a patient with pigmentation and or eczema. We have some examples of pigmentation here and also from eczema. C4B is a patient with lipodermatosclerosis and or atrophy blanche. Some examples here of the signs that we can see on our office. And a C4C is a patient with coronaphylactatic. That means that is a patient that has venolactasias, lactasias, stasis points, capillary confluence of two or more dilated veins of the plantar arch that can be located in the medial or the lateral aspect of their feet. A patient C5 is a patient with a Hillet ulcer, and C6 with an active venous ulcer, and now a C6R is a patient with a recurrent active venous ulcer. And now let's go to the discussion. Thank you.
And with this, we deeply congratulate Professor Santiago. We will get back to him after the last talk of the day that is coming from Dr. Cáceres from Aruba, and we will enjoy him live right after this talk.
Good day, everyone. I am Yuri Cáceres from Aruba, little island in the Caribbean. Today, I'm going to talk you through the chronic venous disease and the epidemiology and the public awareness. These are the topics. Mainly the epidemiology of the chronic venous disease, the venous thrombosis, and the lymphedema, and how important it is that chronic venous disease is, that everybody should be aware of that. If you're dealing with patients, then probably every day, each patient, you have 50% chance of having a patient that has chronic venous disease. That common is chronic venous disease globally. By the age of 50, almost 40% of women has venous problems, and of the men is that 20%. Vein problems are amongst the most chronic conditions. So due to these problems, people lose time of work. This you can see in the next slide, that almost 50% of loss of work is due to chronic venous disease. That's more than arterial disease. So this is a serious condition. If you look at a vein consult program, you see that chronic venous disease is a global widespread problem, because 41% has an early stage chronic venous disease, and 84% has any class greater than the C0s. This you can see in the slide, and the mean age of people having a chronic venous disease is around the 50 years. And in all countries, and you see that a woman has more chronic venous disease than in men. So probably you all know that a venous leg ulcer is an open lesion situated between the ankle and the knee, and that has been present for more than 2 weeks. If you look at the data, then 0.3% has still an open ulcer, and 1% has a healed ulcer. The prevalence of chronic venous leg ulcer is about 1 to 2% in the adult population. This is increasing with the age, and the recurrence rate is very high, up to 69%. So when an ulcer is healed, you have a bigger chance of recurrence if you not treat the condition very well. So we all know that veins and the lymphatic system are inseparable. The veins like the rivers, the lymphatics like the ditches, and if there's a pressure in the one that's higher that has to be addressed with the other. So if there's a lymphatic problem, then the veins will have to deal with it and vice versa. This brings me to the chronic lymphedema. What is a very big problem too? It's like the hidden epidemic. It's under-recognized, it's underfunded, it's undertreated, because many people doesn't know how to deal with the chronic lymphedema. The primary lymphedema, that's the lymphedema at birth, is 1 in 6,000 of the neonates. The secondary lymphedema, the most common cause is the lymphatic filariasis, but we all know that a patient with breast cancer with radiotherapy or surgery of the axilla that has a great chance of having a lymphedema of the arm. Prostate cancer has also a great chance of having chronic lymphedema, and people with obesity, 80% a chance of having a chronic lymphedema. So these are the stages from subclinical to the elephantiasis, stage 4. These are very serious conditions. So what we see later, lately, is that almost the venous procedures rose with 60% from 2013. So this is not because the procedures are minimally invasive only, but this is due to aging, obesity, and low body activity. And chronic venous disease is a serious problem that has to be addressed. But if we look at a study done, we see that general practitioners, less than 50% are aware of the guidelines. And less than 50% of the general practitioner refers C4 and C5 conditions, those are serious conditions, to the specialist. And less than 50% recognizes also the early stages of chronic venous disease. That means that chronic venous disease is very underestimated by general practitioners, even when the signs are present. And if you don't look for that, or if you don't know they're there, then you won't refer for treatment. The other topic I want to share briefly is the deep vein thrombosis and the vein thromboembolism. 1 in 1,000 people each year has a deep venous thrombosis and a venous thromboembolism. Of those people, 5 in 10 are 80 years of age. There's a high recurrence rate. There's a prevalence above the 65 years of 1 on 130. And we can say this is a silent killer, because this is a deep venous thrombosis, is a serious disease that is very preventable. The last slide I want to show is that chronic venous disease has to be a multidisciplinary approach, because there are a lot of disciplines that has linked to this chronic vein lymphatic leg care. Players wins games, but teamwork wins championship. If you work together, then for sure we can treat these serious conditions very well. This is what a briefly presentation of the epidemiology of chronic venous disease. And I thank you very much and wish you a very, very nice 4x4 webinar. Thank you.
Thank you. Excellent presentation, Dr. Cáceres. Brilliant presentation, Dr. Fabricio. Let me introduce Dr. Daly from Jamaica. Dr. Daly, your question to Dr. Santiago.
Excellent presentation, Dr. Santiago. This is Dr. Kevin Kyle Daly from Jamaica. Just one question, please. What is your anecdotal comparative experience in terms of good cosmetic outcome been between using medical management, such as the flavonoid fractions, versus surgical intervention, such as sclerosing therapy, and possibly venous stripping in the treatment of varicose veins? Thank you.
Dr. Santiago?
Yes. So I I don't know if I can answer that question because I have no anecdotal or even randomized control trial experience regarding any publication comparing the aesthetic outcomes by using NPFF when comparing with any other procedures to remove or to treat our varicosities. So I could not answer that, but I could answer that. We have some very nice publications regarding the use of NPFF for surgical procedures and for sclerotherapy. We have a very nice publication from the Russian group from Professor Bogachev, where he compared the use of NPFF before sclerotherapy and after sclerotherapy in a control group. And what they have found is that they had less hyperpigmentation than the group that didn't use the NPFF. And also we have some other publications regarding the stripping as well, with less bruising and less hyperpigmentation. But I'm not aware about the use of the NPFF to improve the venous, the varicosities by itself.
Thank you. Once again, let me introduce our friends and global leader, Dr. Sasa Lazarashvili. Sasa, go ahead.
Thank you, Oscar. Thank you very much, Dr. Santiago. It's very timely, very important presentation. It's very important that at last we have the position of recurrent varicose veins in CIAP classification. And all time it was the subject of discussion. And my question is, in case of recurrent veins, which etiological component from each domain must be acceptable for in presence of recurrence veins? For example, in case of neovascularization, which etiological component will be acceptable?
Okay. This is a very nice question, and we could go on philosophy the whole afternoon to answer that. But by being objective, I think that this could be an inflammatory process and a technical error. So I think we should categorize as secondary, because you can have inflammation during the street tract, revascularization after stripping. You can have a residual stamp for a technical error going to the varicosities on the groin. So this is something that we have caused. So it's an inflammation along and with some hemodynamic defect that we have led on our patient.
Thank you very much.
It's us deeply thanking Professor Lazarashvili also for all the work he has been doing with us in the preparation of these webinars, and Professor Santiago for the constant teamwork and friendship and for being such a good sport. Now it's my deep pleasure to introduce Dr. Panaia in representation of the General Internal Medicine from Italy, a brilliant physician. I have had the pleasure of studying medicine with him in the University of Ferrara, and here is his question for Dr. Cáceres.
Congrats, Dr. Cáceres. How do you suggest us to increase patients' education on venous thrombosis risk in COVID time? Thank you.
Yuri, your time. Unmute yourself. You have to unmute yourself.
I'm sorry.
Here we are.
Thank you, Dr. Panaia. Thank you for the question. Yes, during the COVID times, it's hard for the activity, but the World Health Organization recommends that all adults aging from 18 should participate in exercise, 150 minutes in a week of moderate intensity or 75 minutes of vigorous intensity aerobic physical activity. You should think of walking, running, dancing, hiking. That's if you can go to the gym, then you can go. But if you're in quarantine, then try to walk around the house, doing exercises online. That's one of the part of preventing the deep venous thrombosis. The other thing that the World Health Organization recommends is a healthy diet during your quarantine. So cook healthy meals, get fruits and vegetables, so keeping your body healthy. And if you have COVID, and you have a thrombosis, probably you will be treated with low-rate heparin. So that's what I advise during the COVID time.
Thank you so much, Dr. Cáceres, and I would like to jump on this because it's a topic of great importance since we are talking to many hundreds and actually thousands of people. It is very important to always stay evidence-based. So with WIN Foundation, if you look at the webpage, you will see that there is a project called COVID, where we reported all evidence-based data for the population, for self-management, also at home of the chronic venous disease. It's very important to practice standardized exercises rather than just whatever exercise, because we also demonstrated, for example, that if you simply go walking, but not in the proper way, for example, intermittently or not enough or at the wrong pace, you're not going to have significant benefits. So it's very important to always rely on the vein lymphatic specialists for proper standardized activities based on the evidence. And thank you so much again, Dr. Cáceres, for the brilliant contribution. And now it's my deep honor and pleasure to introduce another giant from the field. It's Professor Hussein from Egypt. We are more than honored the University of Ferrara establishing collaborations also with Ain Shams University that is here representing. So here is his question. Emad, unmute yourself.
Thank you very much for the great initiative, Sergio, Oscar, and Willie, and the WIN Foundation. As usual, inspiring all of us, at least in my region. We realized that we as vascular surgeons were reaching out to colleagues from even far apart from us, and even with the subspecialties that are different from us. So I know I have just a very limited time, in 1 minute or a couple of minutes. I have a tiny comment and a question. So if you allow me to share my screen.
Please, you can. While we are waiting for that, I will go back to what I was saying before, because, for example, we demonstrated that if you go walking with an intermittent pace, like when you walk with the dog, in reality, you get the risk of not activating the pump enough. While if you go continuously at a speed that is a specific speed, we usually say at a speed for which you can speak, but you cannot sing, then you have a real benefit that we published. So now we have the slides and we are ready to move forward, Emad. Emad?
Yes, sir.
You can proceed.
I'll try quickly to go for the...
Oh, we can see the slides.
Yes, okay, great. So this is actually the questions, the comments. Venous leg ulcers, they have difficulty healing, and not only that, they have a high recurrence rate, which can pose a great challenge to all of us. When we face a venous leg ulcer, we expect it to heal within 6 months, but in most cases, it might take even more because of so many factors that need some orchestration by the self-defense mechanism of the body, including processes of hemostasis, inflammation, proliferation, and remodeling, and also a whole array of cellular elements that come into action. So if we consider this, we realize that any alteration of these physiological wound closure process could delay the whole venous leg ulcer healing. And bottom line is that we have still hidden aspects of underlying pathophysiology, and there is a definite need for further studies. Now I would come to the question. My question is, if we consider that venous and lymphatic insufficiency are so interrelated, the question is, what is the usual sequence of events? Which one precedes the other? I mean, clinically speaking, especially in the late phases of CEP 4, 5, and 6. And what is the impact of that on the treatment strategy? The question goes kind of to Santiago and Dr. Cesar from Aruba. Cesar.
Yes, please stop sharing your screen, Amanda, and we will look forward, starting from Dr. Cáceres, who is your contact.
Yes, Dr. Cáceres, please.
Yuri, please.
Yes, we know that the vein and lymphatic system are directly connected to the capillary system, and we know that at a tissue level, in order to transport the venous blood and lymph fluid of tissue, but there is a mutual interdependence in this function. When one of those two systems loses its normal function, a new problem and additional burden of the other system suggests. So it depends on which problem you are dealing with, but it's very important to address both problems. And we used to focus on the venous side of the problems, but if you do not address the lymphatic problems too, then you won't be able to heal only the venous side of the part.
Okay,
Yes,
thank you
great,
so
thank
much.
you.
For this comment, I will add also the arterial part is of great importance, and we have just finished the great project that was dedicated to peripheral arterial and venous disease. And since we are addressing now internal and general medicine, a very interesting concept, and I see we have already questions from the audience on this, is the interrelation between the two things, because often an internal medicine or a general practitioner doctor might have mixed ulcers with an arterial component, where the venous component is frequently present, and taking care of the venous part as well with a reduction of the afterload or the edema by appropriate management is significantly beneficial, of course. So with this, we deeply thank Professor Santiago and Dr. Cáceres and all the group involved in this round, and we move toward at the end, but not before, honorary representative from Central America, because as you know, this project is bringing together Central America and West Indies, reaching out to the world. So we have two brilliant representatives from Central America in the person of Dr. Green and Dr. Camacho. Lorena? Unmute yourself. Unmute yourself.
Greetings to all of you.
Unmute yourself. You're still mute. Yeah, you are.
Okay.
Yes.
Greetings to all of you. It's for us a great pleasure to be able to collaborate Central America, Caribbean, and with this great panel of distinguished speakers from all around the world, to be able to share these importance of basic knowledge of hemodynamics, pathophysiology, epidemiology, and the progression of chronic venous disease. And this is so important because we aimed topics, so clear as transmural pressure relevance in compression and venoactive drugs, and also the importance of multidisciplinary approach, all aiming to the enhancing of the awareness that will improve our patient quality of life. And obviously being able to connect our countries, which are very small if we take them apart, but when we work as a teamwork, united, we can see that we can aim for much higher and much more complex things. It's a great pleasure to be able to address all general practitioners and colleagues from all Central America and the Caribbean. Thank you for joining us.
Thank you so much, Professor Grillo. And now we move to Dr. Camacho, who is another great representative from the region, and here is his message.
Hello, dear friends and colleagues. These are the key points from today's talks. Dr. Giannesini talked about the pathophysiology of chronic venous disease, remarking that physiology is all about the hemodynamics and physics laws. But pathophysiology is also, we have to take into account also the functional capillary density. So the treatment has to be aimed to control the venous reflux and inflammation, and always keep in mind lymphatics. Dr. Hernanan talked about the progression of chronic venous disease and proper treatment, and he remarked that chronic venous disease is one of the most common diseases with a high socioeconomic impact. It is progressive, increases with age, and has propensity to recur. And there's an anatomic progression from segmental to multisegmental reflux. It's also, he also said that secondary disease progression is 4 times higher than primary, and the general progression is 60%. Dr. Santiago talked about the new CEAP classification and the proper symptoms and signs report. There's a last version of the CEAP classification from 2020 with new changes, especially in C2, C4, and C6 classifications, and also with etiology in the secondary etiology. And we have to remember that CEAP is a descriptive classification. And if you want, you can make a checklist of the symptoms going to SIM-VANS consensus. And last but not least, Dr. Caceres talked about epidemiology and public awareness of chronic venous disease, which has a high incidence and impact in lost working days. It is a global disease in which female sex is more affected than male. And also ulcers are very frequent and recurrent. He had remarked that chronic venous disease is underestimated by the general practitioners, and the incidence of deep venous thrombosis and venous thromboembolism is around 1 of each 1,000 people every year and increases with age. So all the factors affecting the chronic venous disease makes this the approach and management has to be multidisciplinary. Greetings from Costa Rica. See you soon in person in the next, in the close future. Bye.
And with this, we deeply thank also Professor Camacho, who has been a brilliant co-worker in the last V-Help humanitarian mission in Santo Domingo, and we look forward for collaborating again in the next one in Guatemala. And now we have time for reaching out to the audience. So let's find out together what we have in the question and answer box, and let's take some answers since we have some time available for this. So I see, for example, for me, how do you measure ejection fraction of the thigh and calf? This is Eduardo Vallefuoco making this question. And do you measure it before and after treatment of varicose veins? Now, the answer to this is air plethysmography is one of the best way of doing that. I don't know if you're familiar with the device. It's basically a cuff, like the one you put on the arm. You put that on the limb. It is very good because it is giving you an objective measure of the hemodynamics. If you really think about that, we usually assess our patients with an ultrasound, which is really fast and practical. But at the same time, this is not really giving an objective measure of all the hemodynamic return as you can have it with the air plethysmography. You have also different kinds of plethysmography. You can also have a strain gauge plethysmography, for example. So basically you have a strip. Another thing is water plethysmography, where you just simply measure the volume. I think it is absolutely important to have this data, mainly in the research arena. So before the evolution of the ultrasound, there was a lot of the use of these devices. Now it is more for research purposes, but if you're interested in objective data collection, I think this is still worth it, having one. We usually use that before and after the procedure for research purposes, not in everyday practice. And it is very interesting because, for example, we usually perform saphenous-sparing procedures, also endovenous ones, but not ablating on the trunk. So we can, and we demonstrated an improvement of the different parameters like venous filling index. And it is interesting because we demonstrated also there was no significant benefit in the ejection fraction in reality, which is really telling us that we should study more this thing of the ejection fraction, as it was reported by the first family medicine representative of the day, because we have to understand more the value of this parameter. So then we have another question. Is there any updated information related to the impact of diabetes on venous insufficiency? Well, I don't know if you want to take this one, Oscar, but we just came out from the great project, as I was saying, dedicated to arterial disease and venous disease at the same time. And we reported that indeed you have more than 25% of patients presenting venous insufficiencies with diabetes, and unfortunately they are highly underdiagnosed. So whenever you see a diabetic patient, always remember to consider also a venous insufficiency, because the two things, of course, can impact to each other. I don't know if somebody else in the panel group has some comments on this, Fabricio or Zaza or Eugene. Fabricio,
I think you've answered correct.
Thank you. And then we have Javier Cabeza, dear friend, writing, do you consider necessary the indication of elastic compression and the use of phlebotomics in the stages of CAP? So, Fabricio Santiago, you have been involved in the update of the CAP class. I would just comment saying that it must be loud and clear, correct me if I'm wrong, that the CAP is not giving us an indication of the severity. Of course, a C6 is a more severe case of venous hypertension, but I would like to go back to my first slide where we were saying that varicose veins are the natural answer of the human body to venous hypertension. And if you really think about that paradox, C6 patients usually don't have huge varicose veins. Fabricio, please take it from here.
Okay, but what was the question again?
The question is, I will read slower, so maybe.
Yes, please.
Do you consider necessary the indication of elastic compression and the use of phlebotomics in the stages of CAP?
Oh, yes, enough of them. So if you have according to most of the guidelines, we have both of them with a high recommendation grading with a good scientific background. You can use both of them or you can use one of them, but it's better if you use it in combination, depending on the severity and the symptomatic patient that you have. So the problem with the compression stockings is always the compliance. We know that, especially in hot countries just like mine. And this is something that sometimes we can use only the phlebotomics. But if you have the opportunity to use both of them, I think the results are going to be better.
Thank you so much. Now, Emad, just 1 minute. We have to move, but Emad, please. Emad, if you want to switch on your mic, you have just 1 minute.
Yes, please. Thank you, Sergio. Thank you very much. Being surrounded by so many giants, we have just been discussing that like a couple of weeks ago, also with Sergio and other colleagues. I think we have not reached a stage where we could, in presence of both PAD and CVI, the ideal patient who is candidate to receive the compression therapy. So I'd like to have the input of both Santiago and Sergio in that.
So I mean, the problem is that nowadays we have to individualize our patients. So regarding, I don't know if you remember the golden rules of using compression on PAD. So since we obey, I particularly have very nice results using compression, depending on the situation, depending on the patient. It could be inelastic or it can be graded compression. We have very nice results using compression, especially with the patients with non-ulcerated patients with mild edema by using compressions between 18 to 21 millimeters in mercury.
So my comment on compression would be that, of course, like for drugs, we want to know the dose. And indeed, it is interesting also to see the parallelism with venous active drugs and the different effects with dosing. For example, take it in the other side. For example, pelvic venous disorders, Gavrilov has recently published the results of different outcomes using different dosages of MPFF. But it's not just about the dose in millimeter mercury I like to talk about, but also stiffness, as Fabricio was pointing out, the stiffness, for example, and also graduated versus compression. Versus progressive compression, meaning more pressure on the cuff rather than more pressure on the ankle. If you really think about that, the vast majority of the blood is in the cuff. So shouldn't it be that the place where we want to eject more? But we have seen also that it really depends on how you are sizing the stockings. We published another paper in which we demonstrated that if your leg is looking like a nice cachaça bottle in order of celebration of Fabricio Brazil origin, or a nice Prosecco bottle, so a different kind of wine from Italy, you will have different interface pressures. So the importance also of putting evidence-based data in the literature where we are always reporting interface pressure measurements, both in B and in B1, so at the level of the calf and the ankle, because if not, we are getting the risk of putting together apples and oranges, as we usually say. Now, thank you so much to you, Amanda, for all the contribution, and then we move forward for the grand finale, because it's really a huge finale for us. We have indeed Professor Caprini, who is experiencing connection issues, but we have his recorded talk with us. You see him here with this T-shirt that is part of a campaign we have been running for quite a long time now with the Win Foundation about never kill a friend, never treat a stranger, about the importance of venous thrombosis risk assessment. So here is his talk, and then we will enjoy another giant, Professor Shaidakov, comment.
Good afternoon. It is a great pleasure to come to you today on behalf of 4x4, which is driving venous lymphatic evidence-based practice forward. As a faculty member for this, I'm proud to be a part of it. This is a part of a non-for-profit initiative developed by the Venous Lymphatic World International Network. The vision is to deliver evidence-based, top-quality venous lymphatic education addressing in particular general practitioners from Central America and the West Indies. The mission is accomplished by an online course structured in 4 modules, including 4 talks each, hence 4x4. Today's presentation is going to involve a topic that's of great interest to me that was inspired by a dear friend in Maine. Never treat a stranger, never kill a friend. What is the meaning of this? Here are my disclosures. Well, we know that fatal pulmonary emboli are the #1 preventable cause of death postoperatively. And so we would never want to treat a stranger because the absence of a detailed history and physical on a new surgical patient to estimate thrombosis risk is a potential fatal flaw if you don't do it. And failure to inquire about family history of thrombosis and obstetrical complications in particular are classic examples. And this is, although it's a time-consuming process, this may be life-saving. Never kill a friend. Once the thrombosis risk profile of a new patient is known by a thorough interrogation, appropriate prophylaxis can be used to protect this person, since the knowledge obtained would be similar to what you would know about the knowledge you would have of a good friend. Appropriate thrombosis would always be prescribed, as you know, to a good friend. Now, how do we do this? We feel that the use of the Caprini score is most appropriate because it's the most thorough history and physical in surgical patients ever tested. There are 40 elements. And we know as the number of risk factors goes up, the incidence of venous thrombosis goes up. And as the power of each risk factor is calculated, it's different. Some are low power factors such as hormones or bed rest, and high powered factors such as esophageal or pancreatic cancer. And these factors and their powers act in a synergistic force, and put together they come up with a number, and that number is a simple number that reflects the incidence of venous thrombosis. As the number goes up, the incidence of clinically relevant venous thrombosis goes up, and sometimes also scan detected thrombosis. Now, these are the results in general surgery, and I would point out that over 5 million patients in over 220 studies to date have validated this risk assessment on all 5 continents. And what we know is that these are various populations, and in the past it was thought that a risk of 5 or more was the highest group. Now we know that that's not really true. Here are the results from that in general plastic and head and neck surgery, around 1%. But take a look at what happens when you go over 8. 6.5% of patients get a clot. These are clinically relevant clots. 11.3% in plastic surgery at 60 days, by the way. And in head and neck surgery, 18%. Whereas in the lower risk scores with head and neck, it's almost 0. So it's very important to know the set point depending on the population tested. Now, we've decided to get patients involved in their health care, and we developed this patient-friendly risk assessment with the aid of some very bright people from around the world to make it as popular and as well known in as many places as possible. Patients take a great interest in their care, and they will huddle together. And for example, that's how you get these family history of thrombosis questions answered, when the family huddles together and talks about their history. And we know that stillbirths, recurrent unplanned abortions, premature birth with toxemia, growth-restricted infant. These are all clinical signs and symptoms of thrombophilia defects, including lupus anticoagulant, anticardiolipin antibodies, or the beta-2 glycoprotein abnormality. And if 1, 2, or 3 of these is positive, as you can see, then the incidence of thrombosis goes up higher and higher. Very important to document these. And If you don't document these and the patient has this problem, that could be the difference between life and death if they don't get prophylaxis. Now, we also know that family history of thrombosis is a very important factor, and there's only 2 risk assessments in the world that I know that specifically ask for family history of thrombosis: the Caprini score and the National Health Score in England. And in England, the National Health Score implementation has resulted in lowering the death rate. And so it's a very powerful tool. And we know that patients, if a patient doesn't have a blood clot, but they have a first, second, or third degree relative with a blood clot, they're at increased risk. And they're even at slightly increased risk if they live with somebody who's had a blood clot. And you might say, what's the story there? Well, perhaps it's related to common habits that those people that live together might have. Now, I'd like to talk about the studies that were done in Moscow by Cyril Lobostov, a brilliant investigator, and the whole Moscow group. Incredible contributions to risk assessment. And they observed in patients with a score of 9 or more, the frequency of symptomatic VTE was as high as 11%. Now, these are very high-risk patients. And those with a score of 11 or greater, the VTE events approached 60%. And this was despite the combination of stockings and low molecular weight heparin prophylaxis. So the investigators thought, what do we do? Do we increase the dose of low molecular weight heparin? Well, that's possible, but that could increase the bleeding risk. So they decided to combine the current routine of stockings and low molecular weight heparin with pneumatic compression. And here are the results. 407 patients were assigned to either be in the control group or the pneumatic compression group. And all patients underwent duplex scans blinded at 12 hours postoperatively and every 3 to 5 days. Low molecular weight heparin prophylaxis was given for at least 7 days or more, and IPC was used for at least 18 hours daily. What were the results? In the group that had stockings, low molecular weight heparin, and IPC, the study group, there was 1 breakthrough thrombosis, 1 patient. Whereas in the control group, which is stockings and low molecular weight heparin without IPC, 34 patients broke through, highly statistically significant. In addition, 5 of the patients in the control group developed PE and 3 of them died. And no PE were seen in the study group, and there were no statistically significant differences between skin injury, bleeding incidents, or PE-related mortality, or total postoperative mortality. Now let's talk about COVID-19. Recently, we completed a study in conjunction with Alex Spiropoulos, who's a giant in risk assessment, and his improved D-dimer score, has been very well validated in medical patients. So we took a look at both of those scores in COVID-19 patients and found the linear increase in scores according to the risk level were associated with both increasing VTE risk and death. And this indicates the value of risk assessment in COVID-19. And we know that further studies are necessary, but it's very important to point out that you need to do an individual risk assessment. Now let's take a look at what happened with the Caprini score. And we notice as it goes up, especially when it gets over 9, almost 30% of people have a clot. Now, what's even more astonishing is that the death rate when it gets over 9 is 80%, compared to when the score is 3 to 4, it's less than 10%. Very powerful data. And so, in conclusion, I would say that it's very, very important to perform a thorough history and physical about the patient in order so that you can know them as well as you know a friend. And of course, you would never hurt a friend. So you'd give them the proper prophylaxis, and you would never treat a stranger because you got to find out things about them first. And by the way, are we treating most COVID-19 patients like strangers without individual risk assessment? So I've included 2 tools here on purpose because there's many roads to Rome. Please do individual risk assessment, and it's critical using your favorite tool in COVID-19. I would like to thank the organizers for allowing me to participate in this program of 4x4 in order to improve the care, especially in Central and Latin America, with key international leaders. Thank you very much, and I hope you all have a wonderful day and stay safe.
And with this, we deeply thank once again Professor Caprini for being always the giant taking us along these educational roads. And another giant we have the pleasure of having with us today is Professor Shaidakov, that I see here ready to go live with these insights, comments, and eventual questions to Professor Caprini. Eugene?
Yeah, dear colleagues, dear friends, Sergio, my pleasure to be today together, and it's fantastic. I really enjoyed this meeting, really enjoyed. So first of all, I would like to thank all the presenters. It was a great session, which I enjoyed a lot. Thank you for refreshing our mind on Capri score. It's a great tool. It's the most comprehensive and the most validated one. Very interesting randomized trial of mechanical prophylaxis with sequential compression devices. I think that it is the tape of the trial and established the highest level of evidence of the already known area. In many hospitals, intermittent compression is used routinely in high-risk patients together with pharmacological prophylaxis. However, I agree that it's important to establish this fact from the evidence-based medicine standpoint. And it is clear that combined pharmacological and mechanical prophylaxis in critical and very high-risk profile patients. Despite our knowledge of COVID disease, expanding many things are still unclear. Emerging evidence suggests that anticoagulation is not necessary in our outpatients. However, appreciate risk stratification in hospital as a patient is very important. My short question to Joy. One of the issues with venous thromboembolism prevention seems to be under-utilization of the individual risk assessment scores, such as Caprini risk score. One way to change this situation is improvement in awarenesses and education, and that's exactly what we are doing now. And I appreciate the opportunity to participate to today's session. Joe, what else do you think we can do to increase the routine use of your risk prediction score? Any thoughts on this? Thank you very much.
Thank you so much, Professor Shaidakov. And unfortunately, we have a connection issues with Professor Caprini, who has been so nice, by the way, to take this difficulty to make the opportunity of sending us an answer right now live, basically. So it will be Khaled playing that, and I will take this chance to deeply thank Khaled Zidan, Mancai Angelinetti, and Gabi Sparcic for being the ones behind all these show that, of course, requires a lot of efforts from the ones we've seen here as faculty, but also on the ones we don't see. So thank you so much, Khaled, for playing this video, Professor Caprini. And by the way, we will have 5 minutes of delay because it was supposed to be just a 3 minutes answer, but Professor Caprini has a special pass with the Win Foundation. He can talk as long as he wants and come whenever he wants because he's truly an example for all of us. Thank you, Khaled.
Good afternoon, everyone. I'm very sorry not to be doing this live, but due to scheduling difficulties, that's not possible. I'd like to thank Maxim Shadikov for his excellent questions, and he raises some very important points regarding the score and also regarding the pneumatic compression devices. I will respond to the score given the time constraints. And first of all, I'd like to talk about the barriers to obtaining the score. Unfortunately, collecting and recording 40 risk factors is a daunting task. And the pre-surgical holding area is the wrong environment. The nurses that are empowered there are trying to make sure that you're having the right procedure done for the right reasons at the right time, on the right extremity, if you will, and that all your labs are in place. It's no time to be asking about a family history of thrombosis. And yet that is done all the time. Another time where it's inappropriate is when you're interviewing the surgeon and the surgeon's explaining to you why you have to have this surgery. You're not interested in your telling about your past history of thrombosis. You're more interested in how long is this surgery going to last? How long am I going to be out of work? Am I really going to be back to normal? What could go wrong? Excuse me. So this is not, again, the right place to ask these questions. And when the patients get admitted, to throw this task on the floor nurses who are already doing too many things, and they're not specifically trained in performing a history and physical, that's inappropriate. On the other hand, people that are taking the history, not understanding the importance of obstetrical complications. I remember recently I was at a morbidity and mortality conference, and this patient had a clot, and I raised my hand and I said, "What's the patient's obstetrical history?" And the head of the conference turned around and said, "Joe, this patient's not having a baby. We're trying to operate on her for cancer." And I said, no, you don't understand. That history in the past may mean that she's carrying a marker of thrombophilia. And so this is another difficult point to get across. And it's in no other risk assessment that I know of. And the other thing is obtaining a proper family history of thrombosis on the fly. But normally when you ask people about their families, they say, oh, everything is fine. You've got to really dig in to get the proper family history. And then there's the other problem, which we still have with the orthopedists, that they don't really believe in all the traditional risk factors that we have in all the other specialties, and are challenging us to prove it in orthopedic patients, especially total joint replacement. Now, to continue on, the guidelines haven't helped us. CHEST 2012 at that time did a marvelous job suggesting for the first time that individual risk assessment could be used, but talked about 2 scores, and the Rogers score was only done in one publication, and since that time it's shown to be not really that valid, especially in trauma patients. And the Caprini score, which at that time had a number of studies, that was very good, but they said that patients who had a score of 5 or more had a 6% chance of getting a blood clot if they didn't have prophylaxis. Now, that may have been true based on what they looked at the time, but that's certainly not true now. For example, patients with head and neck surgery who have a score of 5, very few of them, if any of them, get a clot. But if it's over 8, then 18% in one particular series get a clot, so that the set point is different for different surgical specialties. And this problem was compounded in 2019 when ASH, the surgical guidelines, failed to discuss any of this. They have only one Caprini score article, and it's the original 2005 article. The more than 150 publications from all of you wonderful people from all around the world, and I'd like to stop and acknowledge that. My friends around the world in 5 continents have done the enormous bulk of the work to show that this is a valid and very useful score. And yet that wasn't included, including a nice meta-analysis that was done in 2017. So we're not getting any help there. And the next problem is that there's no individual risk assessment in most randomized controlled trials. They just put everybody in the same bucket, everybody in the same shoe. And the classic example is with COVID-19 and all of those patients, should they get prophylactic anticoagulation, therapeutic anticoagulation, but they're all in the same bucket. And so to say that high-risk patients in ICU on respirators shouldn't get therapeutic anticoagulation may not be right, because although overall it may be true, but if those people have extra high risk factors, then maybe they merit prophylaxis. So that's another problem we have. Now, where do we go from here? First of all, the score should be embedded into the electronic medical record and also linked to clinical pathways. Now, you must assign the healthcare provider responsible for collecting the admitting history and physical to score the patient. Has to be a person that's trained in taking histories and physicals. The score has to be updated during hospitalization, and calculating the final score at discharge, providing continued prophylaxis for those at risk is very, very important, and shown again by Professor Arcelis in the Riete database. Most patients that get the clot get it once they go home. Provide patient-friendly version of the document of the risk assessment on the patient portal. When I go in for an exam, if I have an exam scheduled at the hospital, I'll get this email and I have to go onto the portal ahead of time and put in all my insurance information, my allergies, my medications to pre-register for the visit. Well, what about doing a score at that time if you're going to have surgery? Another thing is you need to require mandatory prophylactic compliance with the care pathways that are set up. Boston and Michigan have excellent care pathways set up, and based on the level of risk, prophylaxis is given for a period of time. And the pathways have to be geared to set points for surgical specialties. It's not everybody over 5. That's inappropriate. A score of 5, everybody that has a total hip has a score of 5 to start with. So what we found is the set point in total hip replacement is 10. If it's 10 or above, traditional anticoagulants are useful. If it's below 10, then aspirin works very, very well. And then one needs to correlate the 90-day clinical VTE rates with the score results. Now, future endeavors, how do we improve this situation? First of all, I've decided to donate the score to the American Venous Forum for a future version called the AVF Caprini score. And there are 5 subcommittees from people around the world looking at revisiting existing risk factors, identifying new risk factors, and defining each risk factor. We know there's a lot of new risk factors that are not in the score, particularly things like sleep apnea, and abdominoplasty is one that needs to be specifically added to the score because that's a higher risk. And there are a number of other things: diabetes requiring insulin, blood transfusions, smoking, AIDS, and so forth. Now we have a very interesting project going, and the first results of this project, we hope will create a interview by the computer to collect the risk assessment using phone. So if you're going to have a visit to the doctor, you can call up this number and they will ask you the score over the phone. Just like when you call up the bank or call up a company, they go through these menus. Now, another thing that we've discovered, which is a secret sort of a finding, was that we're involved with the Global Thrombosis Forum, and the Global Thrombosis Forum is a dedicated 501c3 nonprofit organization dedicated to improving the knowledge of science among young people, especially from underdeveloped countries. And so we have people from all over the world. They're high school students, and we're empowering them to learn more about science. And they did a recent project using the risk score, and they gave it to their friends and classmates with appropriate approval. And in 1 month, they got 1,500 responses back from these students and their families, with a very high incidence of family history of thrombosis in the respondents. And that was because the families huddled together to try to help the students with their homework to get a good mark. And so while that may have been biased, it was biased in a good sense because you collect good data. Taking that data then and putting it into the electronic medical record of the patient after verifying with the doctor is going to be one of the ways that we can improve this. And if high schools all over the world did this, we would really be able to get much better data. And I'd encourage you also all to go to the International Society of Hemostasis and Thrombosis annual meeting with the poster session coming up in the next week or 10 days. And you will see our poster with annotations throughout. It's a very interesting project. Then once we get the new score from the subcommittees, this score will have to be prospectively validated, comparing the new and the old scores. And we're very lucky because we have all of these good friends around the world that will be willing to test this new score compared to the old score. And then the other thing that's really, really key will be the incorporation of machine learning tools. And I'd like to emphasize that a little bit. We know that using the computer, you can fly an airplane, you can assist driving a car. Well, we also know that putting enough information into the from the EMR, you can create a diagnostic algorithms. And this has already been done both in the United States and China and elsewhere, to predict a diagnostic algorithm that will predict VTE incidence. And so you have to train the computer, though. You put the data in from the EMR, and then you do prospective 90-day results. And based on those results and what the EMR, what the machine learning tool estimated, you compare those two estimates and using feedback from actual results, improve the accuracy of the machine learning tool. And then finally, and we're very excited about this, the International Society of Hemostasis and Thrombosis in their committees will take a look at all of the results that we're doing and eventually prepare a document that will outline the sort of the good, the bad, and the ugly about the new Caprini score and how that can be used in everyday clinical practice. So I thank you all for listening to this. Again, I'm sorry I'm not there in person, and I congratulate all the people around the world that have contributed to this project. Thank you very much, everyone, and you all have a great day.
You see the difficulty becoming the opportunity of a 10 minutes second lecture. So we deeply thank once again the giant, and since we have the giant also in the person of Professor Shadok, for one last comment after the lecture / answer of Joe. Eugene?
It's thank you very much, Sergio. Thank you very much, Oscar, and all participants, all lectures. It was really fantastic presentation. It was really fantastic meeting. And answer, Joe, it's not an answer, it's a lecture, not a lecture. It's very, very important for us, for our practice. And thank you very much for the discussion, for their discussion about physiology, pathophysiology, microcirculation, very important compression therapy, and discussion with Fabrizio about MPFF, important to compare, to combine compression therapy and pharmacological medicines. Though it's very important because we don't forget about how important to prevent the early stages of chronic venous disease, how to prevent it and how to treat it in our daily practice. And finally, Caprini score. It's fantastic. Thank you very much again, and for next meetings.
Thank you so much to you, Eugene. I'd like to invite all the audience to have a look at the St. Petersburg Venous Forum initiatives that are, like always, brilliant, and also congratulate the Russian friends for having created guidelines on C1 patients. It's interesting to know that when you have spider veins, in reality, 26% according to the literature of patients are presenting refluxes. So the key message, I think, for the internal medicine colleagues and general medicine colleagues is it's not just aesthetics. You always want to refer to a proper specialist. So let's now go to the conclusion with the last giant, but not, of course, in terms of importance, is one of the first giants, of course, we have in our group, and it will be Professor Bottini giving the mic to this huge expert.
Thank you, Sergio. Let me introduce, it's my pleasure, it's my honor to introduce through Latin American leader and through friends, Dr. Pedro Pablo Comlos. Pedro, tu cierre final.
Unmute yourself, Pedro. Unmute yourself. You have to unmute yourself. No, unmute yourself.
Okay, thank you very much, Bottini. Good afternoon to all colleagues, especially to my neighbors in America. It's a great pleasure, but above all, an honor to be with you today. I'm especially grateful to Dr. Sergio Gianesini and to Dr. Oscar Bottini for the kindness of the invitation. Times, my friends, are very complex. Digital communication, already present in our lives, was greatly exacerbated by the confinement practices required by the pandemic. With that, digital culture started to command finally our lives. Along came the fake news in general and also in veins and lymphatics, which is our subject today. But they came by simple mistake or in bad faith. As this misleading information cannot be prevented, our responsibility as angiologists and vascular surgeons is to take the lead in our activity and promote a constant dissemination of teachings and updates to our generalist colleagues. This is essential for them to know in a scientific but simplified way how to face basic care in attention to chronic problems such as varicose ulcers or recurrent lymphangitis, but especially in severe arterial thrombus or even thromboembolic events with a much increased frequency as a result of COVID-19, this damn virus who came to upset our lives. So thank you very much. Thank you again for the invitation, and let's work in our jobs.
Thank you so much, Pedro. One last comment from Professor Bottini, and then we will close.
Good morning, good afternoon, good evening. Represent to Willie, Sergio.
So it's good to see that Willie is influencing you and is influencing all of us, so it cannot be substituted in reality, but we can have other wonderful representatives of the VWIN vision and mission in the person of Professor Taha. Wasila, one last comment.
Yes, Sergio, yeah. Thank you so much for the opportunity. It has been a great event 4x4. Excellent lecture, distinguished speakers, bright discussion, and the questions came from the floor were really so smart. For you, Sergio, it was a wonderful lecture for the basic physiological and hemodynamics, capillary function, but I would like to add just one point for the morphology. The morphological, as all we know, the superficial venous system is very important to address this point for our GPs and internists. The superficial venous system has very much anatomical variance. And if you'd like to go for the GSV sparing surgery, we have to be very aware and very vigilant from where the source of reflux comes. Dr. Harnan nailed the issue of the progression beautifully. Thank you so much for highlighting that the venous disease is a progressive disease. Dr. Santiago, we discussed this point, but maybe it's about time to change the word inside the new CEP for the C4C, the word corona. I'm really scared to put this word on my duplex or my ultrasound reports or map. Maybe we have to think about it. Dr. Caceres, it's really, I did admire your way for highlighting the epidemiology, highlighting the magnitude of the lymphedema and the hidden epidemic. And of course, last but not least, Professor Caprini and the risk assessment for scoring for the COVID patients, you need to be an individual assessment. I would like to end with all the pleasure to invite all of you, distinguished panel GPs, the audience, the floor, to another bridging with the Latin America and Africa and with another continent. So we call it LATAF 2.1. We did start already in May and June, and we'll resume our site Saturday night main talks next October and next November. And see you all next Sunday with the diagnosis. Thank you so much for the opportunity.
Thank you so much. Thank you so much, Wasila. I see we have also Professor Zaza Salvatore Lazarashvili with us, who is representing the Federation of NENA, so North Africa and Near East. So if you'd like to have a final word as well, Zaza, because you are a pillar of this 4x4. Unmute yourself.
Yeah, Sergio, sorry. It's very important. It's very important to be all times in communication with the family doctors, with all types of primary doctors, because on one hand, it's important because so high epidemiology gives to us the situation when it's not possible to ourselves treat and manage all patients, and we need partners for in this battle, real battle. For another hand, the permanent communication is needed to awareness of these problems, not only for of the superficial veins, but all the vein disease. Thank you to all participants. Thank you to speakers, very interesting, very important presentation, and we will wait next Sunday in the next webinar. Thank you.
Thank you so much, Professor Lazzarashvili, for having been involved in this project from the very beginning, months ago, when we started co-working also with Professor Bottini and Professor Rial. Thanks to Professor Bottini, we will keep on promoting evidence-based, also with the submission of abstracts that is now open for the next September meeting in Buenos Aires. So I invite you to take this great opportunity. I deeply thank all the ones who have been involved in this educational road, including Servier for supporting in a unbiased way this synergy with the general and internal medicine. I stress out the importance of co-working together against fake news in venous and lymphatics, so the possibility of reporting eventually encountered fake news, so to take part in this consensus document that will be presented in the spectacular venue of Dubai during the institutional health week of the once-in-a-lifetime opportunity of the Universal Expo. Now we conclude enjoying Dr. Casserev's wonderful backdrop with a wonderful vision of West Indies. He invited all of us, we are hundreds and hundreds listening to this webinar, so we look forward for the COVID to end and being all together in West Indies in Dr. Casserev's beautiful venue. Thank you so much all, enjoy, and see you next week.
Bye-bye. Thank you.
Take care. See you next Sunday. Bye-bye. Bye-bye.